can also be resulting in bilateral loss, and that is symmetric. There is another variety called the cross coupling, where you have one vestibular apparatus is functioning more, the other vestibular apparatus is functioning less. This is what is called cross coupling or benign paroxysmal positional vertigo. This is by far the commonest form of autologic vertigo, BPPV, benign paroxysmal positional vertigo. The other one is, of course, the fistula and the superior canal dehiscence also can be cross coupling. Look at the air filled middle ear and the fluid filled inner ear. If there is a communication between these two through an abnormal opening, that is called the fistula. An opening in the round window allows the perilymph of the inner ear to leak out into the middle ear. In most cases, there is a small ooze of the fluid between the perilymphatic space and the air-filled middle ear. Such cases are called fistula. Sometimes there will be a superior canal dehiscence. The bone on the superior canal is not formed well. These cause giddiness or vertigo of autologic nature. Let's look at the neurological causes of vertigo. The commonest cause of neurogenic vertigo or neurologic vertigo is vertebrobasilar insufficiency called VBI, or the stroke, the basilar stroke. Then migraine, of course, is a very common disorder, and about 20 to 25% of the patients of migraine do have vertigo, and it could be the cause of 10% of the central vertigo cases. Multisensory disequilibrium, which occurs when the spinomotor tracts and spinocerebellar tracts and the proprioceptive impulses carrying tracts are affected in the spinal cord, and this is an important cause when there is an ataxia in the elderly. There is what is called cervical vertigo. This is a very common neurologic vertigo. This is due to cervical cord problem of various causes. It could be due to cervical spondylosis, it could be due to degeneration of the cervical cord long tracts, it could be due to spinomotor tract degeneration in the cervical region, and so forth. There is another entity called low pressure CSF syndrome, which occurs when there is a sudden leak of the CSF or when the lumbar puncture is done and the fluid is quickly drained out. Patient feels dizziness and vertigo. These are some other important causes of neurologic vertigo. Lightheadedness, faintness, dizziness or vertigo is caused by some of the general medical conditions like hypertension, like orthostatic hypotension or postural hypotension, cardiac arrhythmias, sudden cardiac syncope, vasovagal syncope, or it could be due to hypoglycemia as occurs in diabetes, as occurs in patients who use insulin, or due to medications, particularly antihypertensive drugs which produce vasodilatation, other vasodilators, or drugs which produce postural hypotension. Maybe due to infections like pneumonia, like upper respiratory tract infections, particularly sinusitis. Many patients with sinusitis do complain of giddiness or vertigo whenever they bend their head forward. Acute suppurative otitis media, chronic middle ear infections, all these can produce vertigo or lightheadedness. This vertigo most often is not a true vertigo. It is more a sort of lightheadedness or syncope-like thing. So, after considering the autologic causes, the neurologic causes, and the general medical causes of vertigo or lightheadedness, we are left with a group of diseases which are not difficult to classify, and under these things, the undiagnosed lesions, psychogenic vertigo comes into picture. Somatization disorder, panic attacks, general anxiety disorder, depression, all can present as vertigo or giddiness. Hyperventilation syndrome, a variant of anxiety, also can present as vertigo. And then there are some unknown causes of vertigo wherein we could not work up the patient completely, or the cause could not be identified in spite of complete investigation. In the evaluation of a patient of vertigo, it is very important to clearly make the patient understand what we are asking and clearly understand what he is trying to say. For that, the best way is to go through a series of questions asking the patient about his symptoms. First, ask the patient whether he feels unsteady while standing or walking, or whether the room is spinning around him, or ask him whether he feels that he is moving when he is standing still or when he is sitting. Does he lose balance or fall? As if he is falling, does he feel at any time? Does he feel that he may faint? Some people call this as lightheadedness. And does he feel that the vision is blurred? Does he feel disoriented? That means loss of sensation of time and space and identity. These are some of the important questions which will tell us about what is the actual nature of the patient's symptoms. One important clue for differential diagnosis is the duration of vertigo. In benign paroxysmal positional vertigo, it lasts only for a few seconds. In VBI and TIA, it may be few minutes. In Meniere's disease, it lasts for hours. In vestibular neuronitis and labyrinthitis, it lasts for days. In cervical vertigo, it lasts for months. When it is due to ototoxic drugs, it may be years that the patient is suffering from the symptoms. What is the onset like? Is it instantaneous? Is it acute? Is it slow? Is it episodic and paroxysmal? What is the duration like? Just we have seen in the previous slide. Is it a few seconds, few minutes to hours, days and months? Is it continuous? What are the associated symptoms? Is there tinnitus, pressure in the ear, loss of hearing sensation? Are there other central nervous system abnormalities, other neurological deficits? Are there any cardiovascular diseases? All these together can allow us to filter the symptoms into different compartments, and actually we can see the vertigo into different causes and different types using this approach. What are the clues in the history of a patient for obtaining a proper diagnosis? In BPPV, the vertigo is episodic and lasts for few seconds, and it is associated with the position of the head or body, particularly a change of position of the head in relation to the body precipitates the vertigo. In inner ear diseases, sudden onset vertigo, and patient clearly remembers on what particular day, at what particular time